Hi everyone. For part of my BSN Senior Practicum project, I will be doing a short presentation for PCCU. The goal of this presentation is to educate the unit on venous thromboembolism, or VTE, the prevention of VTE, and the importance of sequential compression device compliance in relationship to this. By the end of the presentation, my objective is for viewers to be able to identify why VTE prevention is so important, be able to identify at least 3 risk factors for VTE in hospitalized patients, have a general understanding of the Caprini risk assessment and Virchow's triad, be familiarized with Claremont Regional Medical Center's policy on sequential compression device use, be able to identify proper documentation for SCD use, and be able to identify contraindications to mechanical VTE prophylaxis per hospital policy. First, I want to touch briefly on what a venous thromboembolism is. A venous thromboembolism, also known as a VTE, is a condition in which a blood clot forms in a vein. There are 2 types of VTE, deep vein thrombosis and pulmonary embolism. A deep vein thrombosis, or DVT, is a clot that has formed in a deep vein, typically in the lower leg, thigh, or pelvis, but sometimes they can occur in the veins of the arms as well. A pulmonary embolism occurs when a DVT clot breaks free and travels to the lungs, blocking some or all of the blood supply. A healthcare-associated VTE is a blood clot that occurs as a result of hospitalization, surgery, or another healthcare treatment or procedure. It is important to talk about VTE for several reasons. The first and foremost being that it is the #1 leading cause of preventable hospital death in the United States, according to the Center for Disease Control. Each year in the United States, VTE affects as many as 900,000 people and results in approximately 100,000 premature deaths, with associated healthcare costs estimated to be $10 billion a year. As many as 50% of blood clots are healthcare associated, with 70% of these having been preventable had proper VTE prevention measures been implemented. VTE is the 5th leading cause of unplanned hospital readmission after surgery. More and more people living in the United States have factors that increase their risk for VTE. That is why it is so important for hospitals to focus on improvements and consistent use of strategies to prevent them from occurring. Next, I'm going to briefly cover some of the risk factors for developing a venous thromboembolism. The Caprini risk assessment was developed by a group of physicians, nurses, and scientists led by Dr. Joseph Caprini as a risk assessment scoring system for VTE. This assessment is used in some clinical settings so that VTE prophylaxis can be individually tailored in order for patients to receive optimal VTE prevention. Since its creation in 1991, the Caprini risk assessment has been validated in over 250,000 patients and used in more than 100 clinical trials worldwide. I've included the Caprini risk assessment in this presentation because it provides an excellent comprehensive list of potential risk factors for developing a VTE. According to Virchow's triad, thrombus formation is the result of abnormalities in 3 key areas: hypercoagulable state, vascular wall injury, and circulatory stasis. The chart you see here includes examples of abnormalities that fall under these categories that place patients at risk for VTE. As you may have noticed, after reviewing the Caprini risk assessment and Virchow's triad chart, the majority of the patients we get on PCCU typically have multiple risk factors for developing a VTE. That is why it is so important that we maintain compliance with the VTE prevention measures that have been ordered by the physicians. Sequential compression devices are one of the methods we use on PCCU as VTE prevention. SCDs are boot-like devices that are applied to a patient's lower extremities that use intermittent pneumatic compression, or IPC, to provide a massage-like motion that promotes blood return from the lower extremities back to the heart. SCDs are considered mechanical prophylaxis for VTE prevention and provide approximately 45 millimeters of mercury pressure at the ankles and 35 millimeters of mercury pressure at the knee. Patients at a moderate risk for VTE generally need either pharmacologic or mechanical prophylaxis, while those at high risk for VTE may require both. There are many benefits to using SCDs. SCDs have few clinically important side effects and can be utilized in patients who are at a high risk for bleed and not candidates for pharmacological VTE prophylaxis. SCDs have been found to be more effective than thromboembolic deterrent, or TED, stockings alone. Multiple studies have shown that SCDs are an effective VTE prevention measure. A meta-analysis that analyzed 70 clinical trials involving a total of 16,164 patients concluded that using intermittent pneumatic compression was more effective than no intermittent pneumatic compression in reducing instances of VTE. Researchers also found that intermittent pneumatic compression appeared to be as effective as pharmacological prophylaxis in reducing VTE. When pharmacological thromboprophylaxis was used in conjunction with intermittent pneumatic compression, the risk of DVT was even further reduced compared to the use of intermittent pneumatic compression alone. Next, I'm going to cover Claremont Regional Medical Center's policy on SCDs. All of the following information has been taken directly from policy number 10317, sequential compression device use for inpatients procedure. The purpose of this policy is to provide nurses and certified nursing assistants with guidelines for the use of sequential compression devices. According to Claremont policy, the responsibility and scope of practice for SCD use is as follows. The physician orders the SCDs. The nurse and nursing assistant will apply and maintain the SCDs once the order is received. The nursing assistant will notify the nurse if the patient refuses to wear the SCDs. The nurse will provide education to the patient and/or family as to the reason for SCDs, the importance of SCD compliance, and the importance of early ambulation. The nurse will notify the physician and document in the patient record if the patient refuses to wear the SCDs. The nurse will document application and continued use of SCDs and education in the electronic health record. The nurse and certified nursing assistant will visualize on hourly rounds that the patient has the SCDs on and that the SCD machine is plugged in and turned on. I have included a video on how to properly apply the Kindle SCDs that we currently use at Claremont Regional Medical Center. If you are watching this presentation on YouTube, I have included a link to this video in the video description. SCDs are not recommended for use in all patients. Some potential contraindications for SCD use include known or suspected acute DVT, phlebitis, severe atherosclerosis, or ischemic peripheral vascular disease, DVT within the last 6 months, pulmonary embolism, any condition where an increase in venous return to the heart might be detrimental, or local conditions such as dermatitis, gangrene, recent skin graft, infected leg wound, or ulcer. Per Claremont policy, documentation for patients who have SCDs ordered must include date and time of application of SCDs, patient family education, SCD use once a shift with nurse shift assessment, and, if applicable, it is okay for anti-embolism stockings or TED hose to be used in conjunction with SCD compression devices directly under the sleeves. SCDs are used continuously unless the device is discontinued by the physician. SCDs are worn when a patient is sitting in the chair in the patient's room. Sleeves can be removed temporarily for bathing, ambulation, physical assessments, physical therapy, and transport. The SCDs are reapplied and the machine is turned on after completion of any activity. The proper fit and functioning of SCDs is evaluated when the patient is repositioned and upon reapplication after bath, ambulation, or activity.